Hello, good evening, good morning. Hello again. Welcome to session 2 of Rhythm Interventions Online 2022. During this session, the focus is left atrial appendage occlusion, and we will get a beautiful update. First, I would like to welcome back our distinct panel. It's Luigi Di Biase and Andreas Rillich. But now, I would like to hand over to our presenter, James Freeman.
All right. Perfect. All right. Well, thank you very much for the opportunity to speak today. I'm Jim Freeman, and I direct the EP lab here at Yale. So I'm going to spend about 25 minutes trying to run through really the updates that we've seen in the clinical research in the left atrial appendage occlusion space over the last year. So kind of the most contemporary science that's really changed the space. I wanted to start just with a bit of an introduction. A bunch of the science that we'll be talking about today came out of the NCDR LAO registry, and this is a registry that was launched shortly after approval of the Watchman device in 2016. And for Medicare reimbursement in the United States, you have to enroll your patients in the registry, and the vast majority of patients in the US have Medicare as a payer. So essentially the vast majority of all patients done in the United States for left atrial appendage occlusion are included in the registry. It includes data collection at implant, 45 days, 6 months, 1 year, and 2 years, has automated and manual adjudication of major adverse events, and they do annualized audits of about 5% of sites to make sure the data is complete and accurate. So I think on that background, we'll talk just about the growth of the procedure in the US. So this procedure has really grown exponentially in the US. By the end of 2021, 146,000 procedures done, and we're well over 200,000 procedures done in the United States over the last several years since approval of the Watchman device first in about 2016. Commensurate with that is an increase in the number of physicians performing the procedure. I'm now over actually 2,300 physicians and over 700 sites in the US performing this procedure. So it's really just grown dramatically. The patients that are getting this procedure done in the United States are generally fairly old and have a lot of comorbidities. So mean age is 76. And about 26% of them have a prior ischemic stroke, almost 40% with congestive heart failure and diabetes. And then very importantly, about 70% of these patients have a history of prior clinically relevant bleeding. So the vast majority of these patients have some relative contraindication to anticoagulation or an absolute contraindication to anticoagulation as a reason for getting this procedure done. So patient preference, while an indication for the procedure, I think is still a relatively modest number of the patients in the US. The mean CHA2-VASc score is 4.6, so very high risk for thromboembolism. And the mean has-bled score is 3, again, commensurate with that finding that many of these patients have previously bled. Despite that, the procedural success in the US in the real world has been excellent. So both the Occlusion registry out of Europe and the recent US data shown about a 98% acute procedural success rate. And I think that's pretty remarkable given how sick and the number of comorbidities these patients have. This is our initial data looking at major in-hospital adverse event rates for patients receiving the Watchman legacy device, the 2.5 device. So this is not flex data, but what we found was that the rates of major adverse events were on the order of 2 to 2.4%. And importantly, really the most common major adverse events were pericardial effusion requiring intervention and major bleeding. And I think that that data really made it clear that the big things we need to focus on are those two major adverse events. Importantly, rates of cardiac arrest, death, stroke or TIA, and major vascular complication were rare. These were all about 1 in 500, so pretty rare events. So we've spent a bunch of time doing science looking at these major adverse event rates, and we focused on a couple of them, and I'll just highlight some of our data. So we recently published a paper in Circ Cardiovascular Interventions looking at the issue of pericardial effusion, again, because that's the most common major adverse event. And it's important to note just how morbid this adverse event is. So the risk of death is 57 times higher if you have a pericardial effusion that's in hospital during the procedure. The risk of stroke is about 6 to 7-fold higher. And then if you have a pericardial effusion in the subacute setting, so after discharge, about a 3-fold higher risk of death. and an almost twofold higher risk of stroke. So just to say, this is a really important outcome, and I think worth really focusing on trying to avoid this outcome, particularly as an in-hospital adverse event. We also looked at device embolization and migration, and this is a much more rare event, occurs in about 7 in 10,000, so sort of 1 in 1,000, under 1 in 1,000 is an in-hospital event, and under 1 in 1,000 is a post-discharge event. When it occurs in hospital, about 60% of patients will have embolization of the device, and about 40% will have a very substantial migration of the device. But this is after the device is deployed. This is the device sort of turning on its side, something more than just a small leak developing. Post-discharge, that flips, and about 40% of them are true embolizations, and about 60% are device migrations. In terms of the risk factors for this, the most common risk factors for in-hospital device embolization are being a low-volume center. The use of the flex device was actually associated with a lower risk of this. So the legacy device had a higher risk of device embolization. And then, not surprisingly, a larger left atrial appendage ostium size was associated with this, and a smaller difference between the ostium size and the device size, which is to say that there may be undersizing of the device. So I think the important take home here is you need to be cautious about larger appendages, and you need to make sure you have adequate compression. Post-discharge, we found that men and taller and larger patients may have a higher risk for this. So that's something to be aware of as well. This is a really morbid event as well. So amongst patients who have a device embolization or substantial migration in a hospital, about 14% of them will die. When it occurs post-discharge, about 4% of them will die. And again, death is a really rare occurrence with this procedure, about 1 or 2 in 1,000. So this dramatic increase in death is, I think, speaks to how important it is to try and avoid device embolization. I want to turn now to peri-device leak, and this has gotten a lot of attention lately, both from our data and some complementary data that came out of the Boston Scientific trial and registry data. So this is an important topic, and I think an important thing for us to talk about. So our data showed that if we looked at about 50,000 people in the LAO registry, about 30% of them will have a leak, about 70% with no leaks. About 26% have a small leak, less than 5 millimeters, and about 0.7% will have a leak greater than 5 millimeters. So that's relatively rare, but leaks are not uncommon. At least, again, this is with the legacy Watchman 2.5 device. And then we looked at outcomes associated with leaks. And what we found was that a small leak versus no leak was associated with about a 15% increased risk of stroke, TIA, or systemic embolism. So we did find a safety signal in terms of an increased risk of thromboembolism associated with leaks discovered at 45 days on TEE. And this is looking at adverse events out to 1 year. We did not see a difference in thromboembolism associated with larger leaks. But again, the recommendations is when you have leaks greater than 5 millimeters to continue anticoagulation. What we found in our data is that was in fact the case. So I think that risk can be mitigated by the continuance of anticoagulation. I think that was reassuring. There was data recently published in JACC in 2022 by the investigators from Protect AF, Prevail, and the CAP2 investigators. They had about 1,000 patients looking at that cohort, and their results were astonishingly similar, actually. So leak rates at 1 year rather than 45 days, about 70% of patients leak-free, but about 30% with some leak, 0.7% with a leak greater than 5 millimeters. So again, very, very similar to what we found. And what they found, again, was an increased risk of non-disabling stroke. No difference in the rates of fatal or disabling stroke, cardiovascular death, or all-cause death. So I think that's reassuring, but a consistent finding of increased risk of thromboembolism associated with leaks. Our take home from this data is not so much to diminish enthusiasm for left atrial appendage occlusion, but really to focus on, during the implant, taking the extra time with the devices that are now redeployable and can be repositioned multiple times to try and minimize leaks to the greatest extent possible. And then I think it's a clarion call to the manufacturers to really do their best to work on device iterations that minimize the risk of leak. We've spent a lot of time thinking about post-discharge treatment, and in particular antithrombotics. And I think this presents one of the greatest opportunities, besides pericardial effusion, to minimize morbidity associated with the procedure. So as many of the audience members and panelists will know, there was a very complex regimen that was designed for PROTECT AF and PREVAIL. Patients had to be on warfarin and aspirin at discharge. They had to have a TE at 45 days. If there was a leak less than 5 millimeters, they were transitioned to DAPT and continued DAPT through 6 months and then transitioned to aspirin. If there was a leak greater than 5 millimeters, they continued on anticoagulation. So a pretty complicated regimen, and it involved the use of warfarin, which isn't commonly used, at least in the United States. So we found that only 12% of patients were following this regimen. And that was data actually from 2016 through 2019. And this number is probably markedly lower in our contemporary data. The most common issue is that people were using different discharge medication strategies. So if you look at the bottom table here, what you see is that the most common strategy was the use of warfarin and aspirin at that time, although I'll tell you that in the FLEX era, with our more contemporary data, we just re-looked at this. Warfarin is now much less commonly used, and it's much more commonly DOAC alone or with aspirin. At least in this data, what you'll see is that about 20% of the patients were on warfarin only, DOAC and aspirin, DOAC only, and then 8% of patients were on DAPT only. So a pretty broad mix of what discharge antithrombotic strategy people were on. Importantly, we saw almost no differences in the baseline characteristics. So it was really just institutions choosing one of these strategies. The one exception to that was DAPT. And so there was data to suggest that the patients who got DAPT were a little bit older and had a higher risk, if you look at the bottom line, of clinical bleeding. And so that suggests that, at least in the US at that time, DAPT was being used in higher risk patients because of the thinking that it might mitigate risk of bleeding. And then when we looked at the unadjusted outcomes, what we found is that the rates of any adverse event were about 1.5% to 2% higher in patients who received anticoagulation plus aspirin compared with anticoagulation only. And this was true both for warfarin and DOAC. And then DAPT was very, very similar to anticoagulation plus aspirin. So again, a pretty substantial difference. We're talking about a 1.5% to 2% risk decrease in the risk of adverse events. And if you look at the fifth line on this table, what you'll see is that that was really driven by GI bleeding and major bleeding. So about a 1.5% absolute difference in the risk of GI bleeding. And so I think this was really important data. And for us, we thought showed there's a real opportunity here to minimize the bleeding. And I think it's important to note that this is just through 45 days. So we're talking about a pretty substantial absolute difference in bleeding through just 45 days. When we did adjusted analyses, this in fact bore out that anticoagulation alone was associated with a marked reduction in the risk of bleeding. So our take home here was that using DOAC or warfarin alone without aspirin may be associated with a substantially lower rate of bleeding. And that does not come at any cost in terms of thromboembolism. So we then looked at midterm outcomes, and in particular, the rate of stroke in the real world. So the question is, is the stroke prevention from left atrial appendage occlusion as good in the real world as it was in the trials? And in fact, our data was extremely consistent with what was seen in PROTECT AF, PREVAIL, and the CAP registries, as well as the Evolution registry, about a 1.5% annual rate of stroke. That's compared with an expected rate of about 6% in patients with a CHA2DS2-VASc score of 4.6. So I think extraordinarily reassuring findings that all of the data seems to be converging on this finding of about a 1.5% annualized rate of stroke. I think the other thing to note is that the rate of death in these patients is not insubstantial. So despite the fact that these patients die at about 8.5% rate, because they have a lot of comorbidities and they're older and sicker patients, the rates of stroke are markedly reduced with this procedure. And so I think that's reassuring, but it also speaks to the notion that we need to be choosing patients who are likely to accrue enough time to benefit from the procedure. All right, I'm going to turn to the most recent data on Amulet. A lot of the data we've talked about thus far is really focused on the legacy Watchman 2.5 device, and then I'll finish by talking about the data for Flex versus the 2.5 device. The Amulet IDE trial, the first 18 months was published, the first 18-month follow-up was published in Circ. last year. I think the take home here was that there was really no difference in terms of primary safety and at 12 months, and then primary efficacy at 18 months. The one substantial difference that I think is worth noting is that the risk of procedural complication was almost twofold higher with Amulet versus Watchman. And this is with the old Watchman 2.5 device. So I think it's something to keep an eye on. But again, by the time you get to 1 year, no difference in a primary safety endpoint. And I think notably, really no difference in terms of all-cause mortality. In fact, in this study, a slightly higher risk of all-cause mortality in Watchman patients. The 3-year data was recently presented by DJ Laccaretti at TCT, and I think importantly really showed consistent findings of no difference in cardiovascular death. No difference in stroke and major bleeding rates. They did see a slightly higher rate of death, all-cause and cardiovascular in the Watchman group. It's a little unclear how to interpret that in the absence of difference in stroke and major bleeding. So I think we need to just keep an eye on that. Importantly, the rates of anticoagulation usage were a bit higher in follow-up for the Watchman device, probably speaking to the fact that there may be slightly higher rates of leakage with that device. Although that's pretty dynamic. And again, we're going to talk about the fact that the Flex device offers some opportunities to improve a lot of aspects of the procedure compared to the legacy 2.5 device. And then this is just a graphic showing that thromboembolism consistently no different between the two devices over time. And so I think that's the big take home here. I'm going to finish by talking a little bit in terms of talking about data about our study looking at Flex versus the 2.5 device. A number of structural changes to the device largely designed to mitigate the risk of pericardial effusion. We did an actual experiment analysis and era analysis comparing sites against themselves. So essentially, if a site had done 35 Watchman Flex procedures, we looked at the 35 most recent Watchman 2.5 procedures that were done at the same site prior to the transition. And I think this study design we were able to do because Boston Scientific essentially in the US asked that sites hand in all of their legacy 2.5 devices within a month after their first Flex. So very rapid transition with no other substantial secular trends in comparing sites to themselves. You can see that resulted in essentially a perfect balance in terms of baseline characteristics between the two groups, very akin to what we get with a randomized trial. So it presents really a great opportunity in the observational world. The rates of major adverse events are about half. So cut from 2.4% down to 1.35%, death down from 2 in 1,000 to 1 in 1,000. Most importantly, the rate of pericardial effusion requiring intervention decreased from 1.23% to 0.42%. And I think this is a really important finding. As we talked about, the two big opportunities with this procedure to improve the safety were pericardial effusion and major bleeding. Pericardial effusion, I think being able to have a device redesign that mitigates the risk of this is really amazing. And then I think working on the post-procedural antithrombotics to mitigate the risk of bleeding, I think will make a big difference as well. In terms of major bleeding in-house, a lot of this was driven by pericardial effusion requiring intervention and markedly lower rates. So I think really reassuring findings that this device redesign resulted in a marked improvement in procedures. Implant success, device success, and procedural success are all markedly improved with the Flex compared to the legacy device. So I'm going to finish by just talking about unanswered questions, things we can do first with real-world data. So I think we need longer-term outcomes for Flex versus 2.5, and we're going to get some real-world data on Amulet in the next year through the LAO registry. We're going to look at stroke, and I think it'll be important to keep our eye on the leaks question and the issue of thromboembolism. It'll be important for us to look again at post-procedural antithrombotics, and I think continue to focus on this issue as a really important opportunity to mitigate bleeding after discharge in that first few months and through the first year. And then a lot of centers in the US are starting to adopt ICE rather than TE for guidance to this procedure, and I think that'll be an important trend to follow in terms of safety and effectiveness. Ongoing randomized trials, we're all aware that Option, Champion, and Catalyst are ongoing. They are going to answer the question of whether left atrial appendage occlusion is comparable or better to anticoagulation in a general AF population without contraindications. We talked about the fact that currently right now, at least in the US, the vast majority of patients getting this have some relative or absolute contraindication. So we need to look at what the outcomes are like in a general AF population. And then I think some possible randomized trials that we may be see coming down the pipeline include looking at aspirin over the long term. This is something that could be looked at, for example, as a pragmatic randomized trial embedded in a registry. Do we need to continue aspirin after 6 months or a year? Or is that really just doing harm in terms of bleeding risk? There's been a lot of talk about the possibility of a LAOS-4 study, and this is anticoagulation plus LAO in high-risk patients to see if we can get rid of the residual risk associated with using either of these alone. So in summary, recent data has markedly improved our understanding of the safety and effectiveness of left atrial appendage occlusion. Post-procedure antithrombotic strategies offer a really significant opportunity to decrease adverse events, and in particular bleeding. Amulet and Watchman, in particular the Watchman 2.5 device, are comparable in terms of safety and efficacy, and I think that's reassuring. The Watchman Flex device is associated with markedly lower risks of major adverse events, and in particular, lower risk of pericardial effusion compared with the older legacy device, the Watchman 2.5. And so I think it's great, and I think a clarion call to the manufacturers to continue to iterate these devices and improve on them. And then the long-range stroke risk with LAO has been very consistent and demonstrates the effectiveness of this procedure in very high-risk patients. So with that, I'll finish and we'll take questions and have discussion.
Great. Thank you, James. That was wonderful. That was a beautiful overview about largely the US experience on the LAA closure. And I am always impressed by the large and big numbers of LAA closure procedures performed in the US. This is very different in Europe and especially in Germany. I had a couple of questions, but this would bring me to my very first question, which is, at least for me, the elephant in the room. From your experience and based on your data, what is the ideal candidate for a patient to perform LAA closure?
Yeah, so I mean, I can speak to who's getting it, and that was sort of some of my opening slides got at that. The vast majority of the patients getting this in the US right now, and I think this is consistent with what we know from the data, are patients who have some relative or absolute contraindication to this. So those are the people that are getting it right now in the US. We are seeing a trend in terms of indications, and I didn't have time to present this data. In terms of patient preference as an indication, people engage in high-risk activities, things like skiing and motorcycle riding and things of that nature. But the vast majority of the patients that are getting it right now in the US have a very high risk for thromboembolism and bleeding, and most have had major bleeding in the past. So that's who's getting it now. And I think until we get good data from Option, Catalyst, and Champion, that's probably appropriate.
Right. Luigi, you look as you want to comment.
Yeah, unfortunately, I have to say that, the selection of medication versus procedure depends also from the law and from the access to the health care. In US, there is a copay that can be low but can be high for medications. So when people think about procedures in a way to avoid having a long-term co-payment for medication, this type of indication is less present in Europe. So this component matters and is reflected into the numbers. Because if you are 68 and you have a Charles Bascom 3 and you have history of atrial fibrillation with or without an ablation with current guidelines, you need to stay on for life. And people will say, I don't have $300 a month of copay. And if there is a procedure that can avoid doing that for me, I want that. So this changed completely the way we approach medicine and the way the decision making has been done. And that's, I think, explained the difference.
Absolutely agree. Yeah, this is a very, very valid and real life point on this. There's a question from the audience, and it's Heiko. He is asking basically and addressing the topic of post-procedural antithrombotic treatment. And you already have shown from based on your data, depending on maybe post-procedure gaps. Maybe we did not go too much into details about DRT, but still this remains also an unresolved topic. In an ideal scenario, of course, we would get completely rid of any anti-thrombotic if that was possible. And the question from our colleague is, what would you recommend? And this is maybe also going to the full panel. After you decide to go for a cardioversion for atrial fibrillation in a patient after an intracerebral bleed, having and carrying an LAA occlusion device. So cardioversion, atrial fibrillation, status post bleed in the brain, and carrying an LAA closure device. James, so maybe you start. What would you decide?
So as I said,
how would you
our data, at least with the Watchman device, is showing that a period of anticoagulation without aspirin may be the optimal regimen. It's a little bit tough. There may be some residual confounding with our DAP data because the DAP patients seem to be a little bit higher risk, at least in the real world. But, you know, and then there's also been some data to look at the use of half-dose anticoagulation. And I think these regimens have been shown to not come at a cost of thromboembolism and maybe offer an opportunity to mitigate the risk of bleeding. And there's a lot of data now to show that the use of aspirin as an adjunct to you know, to anticoagulation or as a DAPT regimen may be associated with an increased risk of bleeding. So I think more to follow, but that's something in general. With regards to patients specifically after cardioversion, you know, the data is pretty scant. There have been some small studies to show it can be done without anticoagulation after cardioversion if someone's had a successful left atrial appendage occlusion procedure, and at least some time is accrued, probably on the order of 6 to 12 months, to allow the device to endothelialize in place. But the data is really comes from very small studies right now. So our practice has been to use some anticoagulation for a month afterwards. But in a patient with a prior history of substantial intracranial hemorrhage or major bleeding, we've definitely foregone that if a patient's had some time to allow the device to endothelialize.
Right. Wonderful. Andreas, any thoughts on your side?
Yeah, first of all, we usually have the dual antiplatelet strategy after left atrial appendage occluder implantation. So we have maybe one group of patients where we definitely use anticoagulation after implantation. This is the patients with the isolated left atrial appendage. So we have more and more patients where we identify a trigger in the left atrial appendage and we isolate that. And we put always an occluder. This may be also a point of discussion here in the panel, how the others do. We always recommend an occluder after 4 weeks. And these patients, they stay on anticoagulation until we are sure that they don't have a significant leakage. And to answer the question of the audience with the anticoagulation after the cardioversion, I think it's more difficult, but we know that in the majority of patients with a cerebral bleed, we can restart anticoagulation again, in particular for a shorter time period. So I would maybe closely discuss this with a neurologist and take into account the clinical history and maybe would give for 4 weeks anticoagulation in such a patient. But I think it varies from patient to patient.
Yeah, excellent. Thank you very much. So, ladies and gentlemen, we could discuss even more, an hour on so many different topics. But unfortunately, we need to close down the session. I really want to thank James for this excellent overview. I also want to thank Andreas and Luigi for your great contributions during this panel discussion. And I am sure we will all meet in person again very, very soon. And I also want to thank, of course, the audience for tuning in. And not to forget that Rio, the main program, will take a short break. But we have a very interesting symposium coming up right after this. And then we will resume the full program for the second half of the day. And therefore, I can only say stay tuned.